Implant treatment is one option that is quite predictable and highly successful. These allow us to expand our treatment options in certain cases we couldn't provide in the past. Sometimes, these procedures cannot be done for the variety of reasons, such as medical issue or financial problem, patient's preference, or etc. It would behoove us to have other available options rather than removal of teeth. Because we are not implantologists first, we are periodontists first. As periodontists, our main objective, whenever feasible, is to maintain the natural, healthy dentition for a lifetime. So most patients, as well as most dentists, want to keep their own teeth for as long as possible. This should be our goal in periodontics, and today my objective is to elaborate on particular treatment option available to us to obtain this goal of maintaining healthy periodontium. So, osteosurgery is a very predictable and highly successful treatment. We've been using this type of treatment for a long time. It's true and tried. So I'd like to go over the history of the osseous resective surgery from the early pioneers and the ones who modified and developed the technique. Then review some articles on the outcome of the osseous surgery, then plan on discussing exactly what you're doing in clinic, where we are going in the future. The use of osteosurgery dates back to early 19th century. First, Robisek described the procedure to allow access to the bone for smoothing and reshaping. Then, Jamtler, Jamsky, Newman, early pioneers, reported the necessity of the access to the bone to remove any necrotic or infected bone. But Kronfeld in 1935 proved that bone tissue under periodontal pockets was inflamed, but it was neither necrotic nor infected. Therefore, it didn't need to be removed. So the necessity of the osteosurgery declined. Then Orban introduced gingivectomy to remove pockets, but lots of clinicians observed recurrence of pockets, which became a concern. So Schluger in 1949, in his classical article, advocated osseous resection and recontouring as the best way to maintain minimal pocket depths. And he outlined the basic principle of the osseous surgery, and the goal is to create a form to the bone that resembles an idealistic architectural form. This is also called ideal architecture, physiologic architecture, positive architecture. Whatever you call it means the same thing. We want the bone topography to be one that is maintainable by the patients as well as conducive to self-maintenance. And as you will see later, we have some clinical cases, so I'll talk to you more. Then Friedman elaborated on the concept of osteosurgery. He classified osteosurgery into osteoplasty and osteectomy. And the definition of osteosurgery is a periodontal surgery involving modification of the bony support of the teeth. Osteoplasty is to reshape an irregular bony contour to achieve a more physiologic architectural form without removal of bone. And while osteectomy is a procedure to remove bone, which is part of supporting structure. But when we do osteosurgery on maxillary molars, we need to consider some anatomical factors such as mesial and distal furcation, which don't exist on lower molars, then buccal furcation, thin buccal bone, and the excess. So the traditional approach is buccal approach, but certain problems may develop from this traditional approach. So let's talk about the problems of traditional approach. We sometimes see interproximal craters with no deep pockets on buccal and palatal side. If the removal of crater is done from the buccal side, we may face reverse bony architecture followed by reverse gingival architecture. In order to avoid this, we need to reduce radicular bone, which increases the chance of location involvement. And human skull study revealed that the bony housing of maxillobuccal molars is extremely thin. And several studies revealed that the thinner the bone, the more bone loss was observed. And the buccal recession in molar areas is now well tolerated as a similar amount of recession on the palatal side. So Oceanbin and Buchanan proposed palatal approach to correct osseous problem, and they claim several advantages. So we have enough keratinized tissue on the palatal side and greater space from the palatal embrasure. Then we can expect some cleansing effect of the tongue, and we have more bone, and together with cancellous bone on the palatal side, we can expect less bone resorption. And they also classify the craters depending on the depth and the topography of the defect. So class 1 is 2 to 3 millimeter osseous defect with thick buccal and